Good afternoon, everyone. Hope you are doing well. Today, we are going to discuss a very important topic, osteoporosis, its evaluation and management. And we are trying to cover the NICE and the NOGG guidelines and trying to incorporate all the clinical aspects as regards bone loss and osteoporosis in this presentation. So let's start right away. Okay, so as I mentioned, today we are going to cover evaluation and management for osteoporosis and try to cover the important points from NICE and NOGG in this clinical presentation. So here we have a 58-year-old lady who is presented to the clinic. Her mother is diagnosed with a fracture in her 60s, a hip fracture in her 60s, and has been taking bone-sparing medication since that time. Now, this 58-year-old lady herself is worried about her risk of developing the osteoporosis and is wondering what we can offer her to reduce the risk. Should we give her some alendronic acid, vitamin D, as well as advice regarding calcium intake? Should we do a DEXA scan, also a DXA scan to check her BMD, perform a fracture risk assessment using a validated tool, or should we reassure her that her age is still less and just concentrate on her calcium intake and exercise? The correct answer for this question, based on the guidelines, will be perform a fracture risk assessment using a validated tool. So here we have a 58-year-old lady and her mother has a hip fracture and she herself is worried about her risk of developing osteoporosis. So what do NICE guidelines suggest? Whom should we do a fracture risk assessment? So fracture risk assessment should be done to all women age 65 and over and to all men age 75 year and over. So this is clear, okay? Now for those women who are under 65 and those men who are under 75, they should have presence of one or more risk factors. If there should be a previous history of fragility fracture. Now, why I have highlighted this point? Because in NOGG guidelines, if there is a previous history of fragility fracture, it is directly for treatment and to do a DEXA scan at a baseline and not for fracture risk assessment in those cases. So even NICE has mentioned here as previous history of fragility fracture, but there is a caveat in this, which I will show you in the next slide. Current use or frequent use of oral glucocorticoids, that's obvious. That is a risk factor as well, can cause osteoporosis. History of falls, so susceptibility to have more falls. If there is a family history of hip fracture, like our patient here in this question, again, it's a independent clinical risk factor. Other causes of secondary osteoporosis is also classified as a risk factor. Low BMI, the BMI should be less than 18, not 18, more than 18 as mentioned here. So if it is less than 18.5 as by NICE and less than 19 by NOGG, this is also a clinical risk factor for osteoporosis. Then smoking, and then alcohol intake of more than 14 units per week for women and more than 21 units per week for men. All these are extremely important because they can appear as in the question stem for the exam. So more than 65, more than 75 for men, more than 65 for women, no need for risk factors. Other lesser than that age group need some clinical risk factors. So as I mentioned to that you about the caveat for the NICE guideline, as you can see here, the 10-year fragility fracture risk should be calculated in all what categories I mentioned there prior to arranging a DEXA scan, except in these category of the people. So over 50 years of age, if the patient has history of fragility fracture. So if the patient is over 50 years of age and if there is a history of fragility fracture in the past, then this patient should be offered a DEXA scan, not a fracture risk assessment first. So this is important caveat. The other thing is that, again, what we have circled here, if there is a history of vertebral or hip fracture previously, so if this fragility fracture, one of them was a vertebral fracture or hip fracture, then we should consider starting treatment without undertaking DEXA scan, especially in those cases where doing a DEXA scan may be impractical or inappropriate. So these are two important points which we should keep in our mind, and this will go in line with NOGG as well. So if the patient is having a previous history of fragility fracture, then in that cases, a baseline DEXA scan should be done, and then if it is a vertebral or hip fracture previously, then a treatment should be offered. DEXA scan may or may not be done depending upon the availability. Okay, so this is very, very important to note in terms of the NICE guidelines. Now let's look at the causes of secondary osteoporosis. So you all saw one point which was mentioned, other causes of secondary osteoporosis. So in that, the most important is again rheumatoid arthritis. Again, rheumatoid arthritis is considered as a independent clinical risk factors. So that's why I've highlighted all these in bold. If there is prolonged immobilization or a very sedentary lifestyle, this is also another cause of secondary osteoporosis. Primary hypogonadism in male because of the testosterone deficiency. Also men and women. So for example, in both these cases, if there is hypogonadism, that can be a cause of secondary osteoporosis, because obviously these will be long-standing. Treatment with aromatase inhibitors or androgen deprivation therapy. So aromatase inhibitors, where we use it for breast cancer, androgen deprivation therapy, where we use it for prostate cancer. I will be looking at all these aspects in the subsequent slides, and these are all the important causes of the secondary osteoporosis. Primary hyperparathyroidism, and that's why we do a checkup for the PTH and the calcium at the baseline, because that is a cause of secondary osteoporosis. Hyperthyroidism, that's why we do a thyroid function test. The TSH should be done as a part of the screening. Post-transplantation, it can occur. It can occur as a part of chronic kidney disease. Certain gastrointestinal diseases can cause it, like Crohn's disease, ulcerative colitis, celiac disease, a very important cause. So we may need to do the screening for celiac disease. Untreated premature menopause, less than 45 years of age, or prolonged secondary amenorrhea is also cited as a cause of secondary osteoporosis. So if there is an early menopause. Type 1 diabetes, so that's important. So it's type 1 diabetes mellitus, chronic liver disease, and COPD. So this is important to remember. Type 1 diabetes mellitus. Sometimes the question they will also give us type 2, but it is type 1 diabetes mellitus. Okay. So all these are important causes of secondary osteoporosis, which we need to rule out. And that's why the investigations which we will do for osteoporosis will be based on ruling out these possible causes. What are the causes of drug-induced osteoporosis? Certain drugs can cause it, like PPIs, certain anticonvulsants, some long-term depot medroxyprogesterone acetate, long-term antidepressants, thiazolidinones, which are anti-diabetic therapy, heparin, and even for that matter, aromatase inhibitors, which I mentioned, and androgen deprivation therapy, which we give for prostate cancer, aromatase inhibitors, which we give for hormone sensitivity breast cancer. So all these are causes of drug-induced osteoporosis. Whom we should not assess for fracture risk, that is advised by guidelines, if the people are under 50 years of age and if they do not have any risk factors. Okay, so they should not have any major risk factors. For example, current or frequent use of steroids, or premature menopause, or previous fragility fracture. These are all already major risk factors. In this all cases, we will need to screen them with fracture risk assessment, even under 50 years of age. But if it is more than 50, if it is not having any of these risk factors, then no need to routinely do a fracture risk assessment. So that's important, whom not to assess. Now let's look at the NOGG guidelines. So NOGG has more of a broader category. So they say postmenopausal women with risk factors. Risk factors are already what we saw in the previous slides. Again, what they mention here, women with a prior fragility fracture should be considered for treatment directly without a necessity of having a risk assessment. However, NOGG acknowledges the fact that risk assessment and or BMD by DEXA measurement may be appropriate, particularly in younger women. So that's the catch here. But prior fragility fracture can be considered for directly treatment with a DEXA at the baseline, which is also matching with the NICE. So I think if you remember it that way, that will be more better and more simple. Men age more than 50 or more with risk factors as above. This is again for NOGG for the fracture risk assessment. How do we assess this fracture risk? A 10-year fracture risk can be obtained by two methods. We can either use a FRAX risk assessment calculator, or we can do the Q fracture calculator. Now, NOGG, okay, so National Osteoporosis Guideline Group advises to use of FRAX. Okay, SIGN is Scottish guidelines that advocates use of Q fracture. However, NICE advises you can use either the FRAX or the Q fracture. Both can be used. Okay, especially if we already have a BMD measurement, then we can use FRAX. Q fracture does not incorporate the BMD measurement, so in that case, obviously, we cannot. If we already have a BMD measurement available, then we can use the FRAX. Okay. Now, FRAX is validated and Q fracture is validated for certain age group. This also we should know. FRAX is validated for age groups between 40 to 90, and Q fracture is validated between 30 to 84 years of age. Okay, and this all gives us a 10-year predicted absolute fracture risk when we are assessing the risk of fracture. So these are the tools for assessing the fracture risk. This is how the FRAX assessment looks like. So You can see it takes into consideration the use of glucocorticoids, rheumatoid arthritis, current smoking, secondary osteoporosis, alcohol. We have also here the BMD measurements if available, which we can input, previous fracture assessment, and of course, the country we can choose for the population as well. So this is the screenshot of the FRAX calculator, and this is how the Q-risk calculator looks. This has more features and takes into consideration more conditions. So you can look at if there is a history of cancer, dementia, chronic liver disease, kidney disease, Parkinsonism, rheumatoid arthritis, SLE. It also takes into consideration the other gastrointestinal diseases like Crohn's, ulcerative colitis, celiac, other endocrine causes like Cushing's, hyperthyroidism, hyperparathyroidism, epilepsy. So if you look at the Q risk calculator, it is more definite in terms of including all the other risk factors for the development of osteoporosis. So this is again more, you can say, clear in terms of clinical aspects. Okay, so that's why important. So here, as you can see, mostly included these categories. In the Q-risk, we have more categories included as well. So NICE advice, either we can use the Q-risk or we can use the FRAX tool assessment. What are the further recommendations from NOGG? Again, this helps us in deciding whether any patient needs the DEXA or we should go for the treatment. So again, that's very, very important. So when we do this FRAX calculator as recommended by the NOGG as well, we see three categories which come up. Okay, so this tool, which when we put all the things, like whether the patient is glucocorticoids, arthritis, and all these things, when we mark the factors, we'll see three categories. We'll see either it comes as a green, where it is called low risk, and there is no need for treatment or BMD measurement, and we just give lifestyle advice and reassurance. If it is amber color, it is an intermediate risk. At this point, we should arrange a DEXA scan to establish the BMD. Then we should recalculate the FRAX score to determine more accurately the need for treatment. But basically, amber means intermediate risk, means arrange a DEXA scan. Red means high risk. These are the patients we need to treat. There is not necessarily a need to measure the BMD at this point. So we have three categories of the FRAX based on the FRAX score as recommended by NOGG: the green, amber, and red. The high risk or the red category, no need to measure BMD. We can go for the treatment. Now, women who have had fragility fracture, again, I'm stressing here, who do not meet further risk assessment, they should be considered directly for the treatment. In some cases, however, the BMD at the baseline by DEXA scan may be helpful. So this is again those women who have had a fragility fracture, as I mentioned. So we have the green category, amber category, and red category. Let's look here more. This all gives us a 10-year probability of a major osteoporotic fracture. You see the green is only lifestyle advice. The intermediate category, we need to measure the BMD and we should reassess the probability. If the probability is high, we need to treat. The red is directly high and we need to treat. So these are all the fracture probabilities by the FRAX tool assessment as recommended by the NORM. Again, coming back to some NICE guidelines, do not routinely measure fracture risk in people less than 50. I already told you, unless they have fractures, unless they have a history of previous fracture, or unless they are being treated with steroids, or they had a premature menopause. So this is very important. Do not routinely measure BMD to assess fracture risk without firstly performing an assessment using FRAX. So as such, the standard guidelines say, and they recommend that do a FRAX first before doing a DEXA scan. But we should always take into consideration where there are other major risk factors present. So this is basically the investigation profile, and this is there in the NOGG guidelines. Out of which the important things which we should know and we should do for the patient is we should get their basic biochemistry. That's extremely important. The renal functions, because that will help us decide many of the medications which we are going to use for the osteoporosis treatment. Especially bisphosphonates may be contraindicated below a certain EGFR. So having a creatine EGFR is extremely important. We should know their baseline calcium, because low calcium and high calcium both are limitations for certain medications which we are going to use, which you're going to see. Thyroid function test, extremely useful. We should have a 25 hydroxy vitamin D3 levels on hand. If the age is more, we can think about multiple myeloma and do the serum protein electrophoresis. We can also do the other tests based on the symptom presentation, serum testosterone, or we can do a ruling out the Cushing syndrome. So we do the 24-hour urinary cortisol or the overnight dexamethasone suppression test. We should do a PTH. So at least the basic things are like calcium. We should do a creatinine. We should do a vitamin D. We should do a what we can say, PTH hormone, and vitamin D3 is very, very important. Okay. And lateral radiographs of the lumbar and thoracic spines are helpful as well to see if there is any fractures. Other investigations are depending upon specific cases. They may be needed like bone biopsy or genetic testing. But these are in general the baseline investigations which we are looking at when we are investigating osteoporosis. Monitoring or recalculating a fracture risk, what do guidelines recommend? Recalculating fracture risk should be done after at least 2 years, or if there is any change in the percent risk factors. So just to keep in mind this recommendation from the guidelines again, when to recalculate the fracture risk, recalculation of the fracture risk can be done after 2 years. Now, what is fragility fracture? So fragility fracture is a low trauma fracture, okay? That is a fracture sustained as a result of a force equivalent to the force of a fall from a height equal to or less than that of an ordinary chair. So that's a very small height. From if you fall from that height and if you get a fracture, then that can be labeled as a low trauma fracture or a fragility fracture. Osteoporotic fragility fractures occur most commonly in the vertebrae, the hip, and the wrist, and are associated with substantial disability, pain, and reduced quality of the life. So that's very important to note. Fragility fracture is a low trauma fracture. Now, suppose if a patient had a previous history of fracture and that was after a road traffic accident, that we cannot label it as a fragility fracture. So when you see in the question stem, very important to see whether it is a low trauma fracture or if it is a fracture due to some other cause, like a road traffic accident in that case, and that case will not be labeled as a fragility fracture. Now, these are again very important things, clinical risk factors or indicators of the low BMD. Now, clinical risk factors, as I told you, there are specifically defined by NICE. So these three we should remember, okay? Because many of the agents which you are going to use are also going to take this into consideration as well. So parental history of hip fracture, alcohol intake of 4 units or more per day, and rheumatoid arthritis. So these three clinical risk factors are called independent clinical risk factors. So they should always be remembered, and they are very important questions for the exams. So these three: alcohol, rheumatoid arthritis, and parental history of hip fracture. Okay, you can remember it by the mnemonic like hair, hip fracture, alcohol intake, and rheumatoid arthritis. Indicators of low BMD, again, there are 4 specific indicators: low BMI, medical conditions such as ankylosing spondylitis, Crohn's disease, conditions that can result in prolonged immobility, and untreated premature menopause. So again, these 4 have been defined by NICE. Again, they appear as question in the exams. Indicators of low BMD, we have a low BMI of less than 22 as defined in this definition. You saw in the previous definition, it was less than 18.5, less than 19. But in this definition of indicators of low BMD, we have a low BMI of less than 22. We have a medical conditions like ankylosing spondylitis, Crohn's, conditions that result in prolonged immobility, and untreated premature menopause. So this is in basic about the WHO guidance as regards the T-score and the Z-score interpretations of a DEXA scan. Now, normal is more than -1. Okay. In terms of osteopenia, if it is -1 to -2.5, it's called osteopenia. If the T-score is less than or equal to 2.5, that is called osteoporosis. And if the T-score is less than or equal to -2.5, plus there is a previous fragility fracture, then that is classed as severe osteoporosis. So very important to remember. In patients who are not above 50 years of age, so basically T-scores are used if postmenopausal woman or man more than 50, or if there is a previous history of fragility fracture. So here we use the T-scores. Otherwise means if there is a premenopausal woman or men less than 50 years of age, children for that matter. In these cases, Z-score is what is used. So normal Z-score is anywhere between -2 to +2. A low BMD via Z-score means if the Z-score is less than or equal to -2. So that is important to remember. So Z-score is basically comparison of the patient's bone mineral density to an age-matched population. In premenopausal women and younger men, the relationship between the BMD and risk factors is not well established. Hence, Z score is more relevant than the T scores in the premenopausal women and men under age of 50 years of age. So that is the basics as per the WHO classification and also mentioned in the NOGG guidelines of 2017 for the DEXA scan interpretation. Now, important is also to look at the site of measurement. So DEXA measurements at the spine and the hip are the most recommended because these fractures have the greatest impact on the patient's health. Measurement of the hip BMD also has the highest predictive value for a hip fracture. In addition, if a pharmacological therapy is planned, okay, so spine BMD is useful as it shows less variability and can detect responses earlier than the hip BMD. So when we are seeing a response to any anti-resorptive therapy or, for example, any anabolic therapy which we are giving for the patients, measurement of the spine BMD is the most useful because that helps to detect the changes earliest compared to even the hip BMD. And hence, as a response to treatment, the spine's BMD changes are the most important. On the other hand, in elderly people, and elderly women and aging women, interference from the osteophytes and the vascular calcifications on the spine measurement are common in aging women, and this can interfere with the measurement of BMD at this site. So in this setting, in setting of an aging woman, and if there are osteophytes and vascular calcifications, then measurement of the hip BMD alone or a hip and 1/3 radial site is sufficient. So in these cases where there are osteophytes or there are vascular calcifications of the spine and the spine measurement in this case may not be very reliable, then measurement of the hip BMD alone or hip and 1/3 of the radial site is sufficient. So that's the important clinical aspect as regards the site of measurement. So the spine BMD detects the responses earliest to the therapy more earlier than the hip BMD. In terms of the aging, if there are osteophytes and vascular calcification, a hip BMD or a hip and 1/3 radial side BMD is more better than a spine BMD. When does a forearm BMD become more important? So we looked at this slide that the spine and the hip BMDs are DEXA measurements are the most recommended. So when does a forearm BMD? So the free view of this particular lecture has ended. For access to this full lecture session, please subscribe to my lecture series, which is total of 60 lectures till date. These will be provided access to via paid subscription plan, and all the paid subscribers will be given a lifetime access to all my existing 60 videos lectures, which are already on the YouTube channel, plus all the upcoming new videos. So whatever lectures or sessions I'll be doing in coming weeks, months, and years, all of them will be given access to in the same subscription plan. So for the full subscription details, please email me on mazirules@gmail.com or WhatsApp me on 009715574344794 and have the same number on the Telegram app as well. Just to give a brief overview of the full lecture series, so it includes different topics across diabetes and endocrinology. For diabetes itself is around 19 lectures which I've done across different topics which are useful for the exams as well as for the clinical endocrinology practice. In terms of high yield topics for specialty exam and European board exam, there are around 9 sessions which have covered all the previous exam recalls as well as all the high yield topics and themes which are frequently encountered in the specialty exams and the European board exams. In terms of thyroid, apart from the thyroid cancer guidelines which were recently published, plus there are other sessions on different topics related to thyroid across the spectrum of thyroid disease. In terms of adrenal as well, covering all the important topics or sessions which are frequently encountered in exams and in clinical practice. There are 2 very good sessions on lab endocrinology by Dr. Velmurugan, very helpful for those preparing for DM Endo or DNB endocrinology as well. In terms of pituitary also have covered all the important sessions on all the important topics which are frequently encountered in clinical practice and the exams. There are a few sessions on the inherited endocrine syndromes as well. Very important sessions on reproductive endocrinology, about congenital adrenal hyperplasia, gynecomastia, hirsutism, PCOS, diagnosis, evaluation, management. There is a sessions on calcium and bone metabolism, on familial lipid disorders, and sessions on pediatric endocrinology as well. So just to let you know that there are many more sessions coming up, and as I mentioned, that in the same subscription plan or same subscription fee, you will be provided access to all my existing 60 lectures plus all my forthcoming lectures. So thank you very much for subscribing. Thank you very much for supporting.